Good evening, everybody. Last talk of the day. Most of the topics I was going to cover has been covered already. I'll just reiterate with a different perspective. Uh, how do I use rapid diagnostic during evaluation of infection? This day and age of machine learning, machine diagnosis, we have become more of a machine doctors. So, what a ideal rapid diagnostic set should be, it should be able to give a result quickly, and the result should be reliable, and it should be able to detect the microbe in lowest concentration. It should also be enable high throughput testing, which means that we should be able to test more samples in a day. It should be able to identify a specific organism and also identify the sensitivity for the organism. So this is what we would do. And also, if it is directly from a clinical specimen, which is now upcoming, will be better because it doesn't need the processing time of culturing and subculturing and using the sample. So what are the available tools? Of course, clinical, and we always debate if there is a sepsis or no sepsis for a very long time. And scoring systems are available. Laboratory can aid us, and biomarkers can aid us. And so coming to scores, so we all know that the sepsis definition came with this Q-SOFA score, and then now the Surviving Sepsis campaign actually has said don't use that score because it has a low sensitivity and specificity. So they have compared in this study various scores and found that they are actually not very useful in detecting sepsis. So clinical pathology, you can do the usual counts. You can also see the cytomorphometric markers in neutrophils and monocytes. Now there are systems available where you see the size of the neutrophils, monocytes, and the distribution. And use the CRP and procalcitonin, and that actually aids in strengthening your diagnosis. This is a study done in our institution, which showed actually that a cytomorphometric neutrophil can also be useful in diagnosing. So all these tests can be run quickly and may not be available in all the laboratories. So we all heard about procalcitonin and how good it is for discontinuing antibiotics, and the guidelines say don't use it for diagnosis. And these are the various biomarkers available in addition to NGAL and things like that, prosepsin, etc., which are useful, but they're all still in laboratory phase, in research phase. So you have a sensitivity and specificity of about 75% for septic shock, 75 and 66 for septic shock, and so these are all actually not very specific tests which we can use. So the key is to identify the cause. Now we are looking at the effect of the sepsis. The key is to identify the cause, meaning identify the microorganism. So you also should know the sensitivity pattern, and which we can decide on the choice of antibiotic, de-escalation and escalation, and use the antimicrobial stewardship. This is how a rapid test will help us in reducing the cost of treatment, reducing the exposure of unnecessary antibiotic, and prevention of emerging antibiotic resistance. So what is available? So normally we send a blood culture. We inoculate into this Vitek bottle. It goes into the BACT alert system, and when it is positive, it flags up. So the other way is, can we do it directly from a blood culture? There are research tools available. Maybe some of them may be available in a commercial thing, but we are not having anything in India. What we have in India is, after the blood culture, you can have these two. You can have the Vitek 2 ID. It will basically identify the organism and identify also the resistance pattern, or the MALDI-TOF system. Or you can, from the culture, so from the culture from the blood culture you do a subculture and then do it, or directly use the sample from the blood culture bottle, and you can do this Gene Expert and BioFire, etc., which is actually the BioFire company is there. And I found a lot of new information after coming here. I got some of the slides from my presentation is from the microbiologists from my lab, as these are the systems they use in Vellore. So this MALDI-TOF, it can actually detect the organism, and you have the syndromic panel, and depending on what the syndrome is, you can do this, and it also identifies the organism. It will identify the resistance pattern, but it will not tell you sensitive pattern. So what we are worried about the resistance, whether it's a bacterial, fungus, or a virus, and then you look at, is it an organism which is common in your place, and you look at these sensitivities. That will give you the resistance patterns. The other test which is available is the Carbo Expert. Again, it will identify all the types of ESBL, and which is useful in deciding on the antibiotic in the ICU. So you start on an so this is what we do when we see like a Klebsiella pneumonia, which is very common. So we do the cultures and we start empirical therapy with meropenem and colistin. And from the microbiology lab, say day one, we get the culture and they do the Carbo Expert, and they will obviously they will alert the clinician. And if we find a OXA48, we will change to ceftazidime avibactam. But if we have also NDM associated with this, then we'll change to aztreonam. So this is how within 2 days we will be able to give the appropriate antibiotic when we use the Carbo Expert test. So there are various tests available. In this, we have the BioFire, which actually, this is from the blood culture. We have different panels for the blood, for the respiratory secretions, for virus and bacteria, also for even the gastrointestinal specimens, and now they are coming with for the joint fluid also. So if you go to the stall outside, you'll find the information, this booklet, and you can use directly the samples and you get the results within 2 hours. So you see what the if there is an organism, what is it, and is there a resistant pattern with it? So these tests are available, and which will be very useful to implement to decide on the antibiotics. So this is the kind of blood panel. You can see even the bacteria, gram-positive, including the yeast. And for the pneumonia, you have this is for the viral. You have a separate panel for viral, which includes the COVID virus and also for the other viruses. So depending upon this number of, so this is for Acinetobacter baumannii. So you can see whether it is colonization or an infection, and you can decide on the treatment. It gives you the sensitivity also to various antibiotics. So we don't have a system for a rapid AST. You have the Vitek system for the rapid AST, but it takes about 48 hours. You same Vitek bottle, you inoculate, but it gives you the organism identification and sensitivity, which takes up to 48 hours. So you need to wait for that time if you want the sensitivity. So what is the evidence? It's all theoretical, this thing saying that, okay, rapid diagnostics will help, but evidence, there is some evidence. This is a systematic review of about 850 patients, which shows that the risk of death, the length of stay in the ICU, etc., reduces when you do the molecular-based rapid diagnostic test, but in association with a good antibiotic stewardship program. Without the antibiotic stewardship program, it does not work. So if you look at this, it tends towards using favoring the molecular rapid diagnostic tests. So here also there is another study which shows that if you use the rapid AST, you actually de-escalate, change the antibiotics and change to oral antibiotic much quicker than using the conventional thing. So Cochrane did a review which actually did not show any evidence of use of these rapid tests, but with more evidence coming into the literature, we will find that it may be useful. So direct specimen testing is what we need, because that will give the lesser turnaround time. Culture delays at least 24 hours, so that will delay. And now when we know the bacteria, we know whether it is sensitive or resistant. You know what ESBL gene it is, if it is there, and then you can appropriately titrate your antibiotic based on this genomic resistance. So when it comes to stewardship and how we can improve treatment in terms of rapid diagnosis, so clinical vigilance is very, very important. Appropriate culture. So many centers, many trainees, they'll send urine culture straight away. They'll send a ET aspirate straight away without any evidence of there is an inflammation. So you do a urine microscopy first and then do a culture. Because if you find something in culture, but the microscopy is not suggestive of infection, you're not going to give antibiotics. So appropriate culture. So diagnostic stewardship is very important. timing of culturing is very important, and communication, especially with the clinical pathologists or clinical microbiologists or clinical pharmacists, where you can do TDM, etc., is very important, and of course the ID physician and antibiotic stewardship. So, if you ask me, these are the very important steps in terms of rapid diagnosis and treatment, in addition to all the laboratory aid for diagnosing infections. I'm sure you never expected mobile phone to become such small. The whole world is in your pocket now. So I'm sure we'll get tests which will turn around with 2 hours time and tell you what the AST is. Thank you very much. This is my new hospital in Vellore, 1,000 by 500 bed modern multi-specialty. Well, it's a super specialty hospital. Thank you for the opportunity.